think we stick to the English, and I am now in this sandwich position between now and lunch to have new challenges in control of infections of migrations and refugees. This year, for the first time globally, we face that we have 65 million of forcibly displaced people worldwide. This is a new challenge globally. This has not occurred so far in modern history. Of these, more than 20 million people who are actually refugees. More than half of them, 55% of these persons, come from only 3 countries, from Somalia, from Afghanistan, and from Syria. If you are interested in the topic, there is a very, very nice interactive website from the International Organization of Migration. You just put in IOM and you really very easily you reach this map. And if you surf on the map, you can click on each and every country and you see the number of migrants or refugees which have left that country and where they have gone. And the other way around, you could also opt on, let's look if a certain country has received a certain number of refugees and migrants. It is very fascinating, these numbers also, to see the differences between acceptance and between non-acceptance of migration. These 65 million which are now displaced, 12.5 of these are people which are internally displaced. And then we have the group of nearly 4 million who seek asylum elsewhere, not in their home country. And the UNHCR has calculated that this means 24 persons every minute. That is a magnitude we have to become aware of. If we would put these 65 million people in one nation, this nation would rank as a country number 21 in the world rank. So it is really a huge dimension. Let's look if this is really new. The main destination countries for new asylum seekers in the last decade is indicated here. We see that there is a quite stable corridor of numbers which is beyond the 50,000 a year. So it is a couple of 10,000 people a year in the period between 2006 to 2013. For all the major countries receiving here, like Germany, the United States, like Sweden, the Russian Federation, Turkey, or Austria. And then we observe a newly trend that a kind of explosion in numbers of new asylum seekers have occurred, and you see that these countries all are affected by that. But also you see that there are a couple of countries like Sweden and Germany who took the majority of these asylum seekers. If we look to the age distribution, then we see that it is usually young men in the age of between 20 and 40. There is a small proportion only of elderly persons, and there is a not so small proportion of kids, sometimes being alone on their own, unaccompanied minors, which also puts a lot of stress to the countries. If we look to the hotspot of forced displacement globally, then we see that there is one issue in Latin America. This is Colombia, mainly inside the country displacement. And then it is the Middle East, the Middle East and African country, and this situation in the Middle East is at our front gate in Europe. There is no other continent where these people have a rationale to look for assistance or help. This puts us also in the medical community to a kind of ethical position we have to take. Physicians, nurses, our professional target is to support people, to help people. And then we should be aware that the reasons of displacement and refugee or migration are not insufficient protection of borders, but it's wars and exploitative system in the countries and inequitable redistribution of wealth. No one usually leaves his home country just for fun. These people have good reason to become. So if we want to work on the causes to change that, we have to be interested in these situations in the home countries. And we have to take our responsibility in developing aid, in making a good political support around them. As Germany is receiving the majority of these asylum seekers currently, then I looked to the history of asylum seekers in the years from the Second World War, so this is covering 60 years. And you see that we already had a situation in the early 90s at the collapse of the Soviet Union, where we received an equal number of asylum seekers, mostly at that time with a kind of German heritage from Kazakhstan and Siberia and other parts of the former Soviet Union. Then these numbers were going back, and only in the last 2 years we have now a number of more than 500,000 asylum seekers per year registered. If we look to the countries of origin for this year, the first 5 months in this year, you see that nearly half of them coming from the Syrian Arabic Republic. 14% coming from Afghanistan, 15% from Iraq, and also some countries like Eritrea, Albania, and the Iran Islamic Republic. This is the pattern of heritage of now people coming not only from different cultural systems, they are also coming from different healthcare systems. And their status of health is connected with the performance of the healthcare system of their country of origin. If we look to the question, are now we receiving more imported infectious diseases which are reportable? In the first 5 months this year, we have a total number of reported infectious diseases in Germany of 160,000. Only less than 4,000 of them have been reported by asylum seekers. This is something like 2% of all reported diseases, whereas the population is less than 1%. So the probability or the prevalence of reportable infectious diseases in that population, yes, it is the double of the average German population. But if we look into detail, and these are the numbers for the last year, then we see the majority of these had been varicella. And this was not varicella brought on the way from Syria or Afghanistan. That was varicella outbreaks due to the conditions of housing of refugees when they are in jointly in schools or in sporting palaces or whatever, where then these varicella can spread. Especially if they come from countries where a varicella vaccination is not part of the vaccination program. The second important importance of reportable diseases are in fact tuberculosis. Then we see also some hepatitis B, and some rotavirus or norovirus. Also these acquired in the country they are living now. And then there are some very rare diseases which had been observed. The scale of this map is very different. We saw less than 10 of typhus, of mumps, of tryptosporose, or of louse-borne rickettsia. The age distribution of the reported cases of asylum seekers show clearly that this is something the varicella have triggered, as this is under 4 years of age, the main age group which has reportable diseases occurrence, and then the group between 15 and 30, the men. What are the countries of birth of the reported cases? And Syria takes the main part, then it is Afghanistan, Iraq, Somalia, Eritrea, Iran, Pakistan, Albania, Russia, and Nigeria. So this is quite proportional to the number of refugees we received. So of course at the beginning there was much concern, does this really add an additional risk for control of infectious diseases in our country? Yes or no, and we would like to know more about that. When someone comes into the country, in the first 2 days, there is a physical examination, there is a vaccination of TDP and polio, IVP, and then there is a MMR vaccination if there is no evidence shown by presenting a international certificate of vaccination. In doubt, the vaccination is performed. And as well, an X-ray is done by all those over 18 years of age and being non-pregnant. So that is the on-entry situation where we do this kind of health check. And the Medical University of Hanover had calculated that there is 1 in 5,000 in 4,001 open tuberculosis detected, and the suspicion of tuberculosis is 20 in 1,000. But interestingly, we see also the seroprevalence data, and we see that for HIV, for measles, for rubella, and for varicella, we have more than 90% coverage of seroprevalence of specific antibodies, so that we don't have really a challenge in that. Of course, we were curious to know something about the polio situation, as we knew from Syria that they had some polio type 3 detections in the country, and we doubt in this civil war situation how they can maintain a vaccination program. And therefore we interestingly look to the polio antibodies in refugees, and we see it is above 80, even 90%, regardless if the refugee came from Iraq, from Syria, from Afghanistan, from Somalia, and from Pakistan. And even if you look to the age distribution, you find this isn't true also for the kids, but also for elderly people or for adult people in the age up to 40 years of age. So we do not assume that we really have a lack of protection in refugees on that. What is the reason for seeking medical care? Usually it is not a necessity of being hospitalized. We have a half and half adult and pediatric request. We see that most of them, 4 months of one contact is enough. And what we see is that respiratory diseases are the majority, then gastrointestinal uncomfortabilities, the second from then derma, neurologic things, vaccinations, and a few others. If you look to the reported cases again, that it is varicella, it's tuberculosis, it is hepatitis B, hepatitis A and C, and also influenza in the settings they are living in it. We also observe sometimes very rarely known diseases for the German health system, and this is necessary to educate the doctors again that this might occur. There is louse-borne relapsing fever, which we have not seen for years in our country. Now we had 10 cases last year, 5 cases this year. We are very rarely seeing typhoid fever. The amoebic liver affections are also very uncommon. There's a nice map from the ECDC. What are the geographical tracks where this louse-borne relapsing fever is brought back into midst of Europe? The major findings from the physical on entry examinations are the missing vaccinations from varicella and measles in particular, which can be, of course, dealt with by vaccinating them, the respiratory diseases, and the risk of outbreak due to the pure hygienic conditions they are usually in the first weeks in. The conditions of housing also brings a higher prevalence of scabies, which is occurring, and of course of influenza. Therefore, in these conditions of housing, we usually offer actively influenza vaccination. There is indeed a higher prevalence of TB. The prevalence of the TB in refugees is 10-fold higher than in the German population, besides the foreign population in Germany, which is more than 10% of the entire population at the moment. And also, we see a higher prevalence of MMR and of multi-resistant gram-negative bacteria, which especially is a challenge to the obstetric departments when young mothers deliver in these settings, and we do on-entry screening for both MRSA and for the multi-resistant drug when a hospital admittance is necessary. There's a lot of health promotional material out, which is now available in all of the target languages of the refugees, and this is important because usually the language skills of the refugees do not match with any language skills of a German doctor or nurse whatsoever. So we have a communication problem and a cultural problem because the patient is not seeking an ambulatory service alone, but usually they come in a family setting, and this is disrupting the ordinary procedures of healthcare providers. In my own place, we also calculated that, and you see that the most common diseases are not really infectious diseases, but the usual things, a lot of also psychiatric diseases, also in the conjunction with the fear of being forced to go home again. Cultural difference, language barriers, the understanding of the patients, the patient's motivation for visiting a doctor, the deportation issues in that, the discrepancy between expectations and treatment possibility, and what do we know about the patient's compliance. The questions if refugees are a danger for highly contagious diseases can be answered with no. These diseases are not prevalent in the country of origin, and the incubation period is shorter than the duration of travel. The conclusions of the Robert Koch Institute is asylum seekers are more a population at risk than a population than a risk for other populations. We can deal with these challenges very good, and if you come into the situation to care for these people, one of the best websites on that is the Refugee Toolbox for the Med Boxes, refugeetoolbox.org, and you find in a variety of languages, you find whatever you need to serve on that. Final statement. We as physicians are usually not responsible for the political situations which causes these migration. And we should remind ourselves on the Universal Declaration of Human Rights, which said in the Article 25, that everyone has the right to a standard of living adequately for health and well-being of himself or of his family, including food, clothing, housing, and medical care, and necessary social services, and the right to security in the event of unemployment, sickness, disability, widowhood, old age, or other lack of livelihood in circumstances beyond his control. So the German Federation of Physicians asked to make no difference in healthcare provisions for our population and for asylum seekers, not a second class of medical performance, which is also health economically sound to do that. Thank you very much for your attention.